Welcome back to the next edition of Dr. Twyman's Ask Me Anything. Back from the nature reconnection at the getaway, now postcard cabins. Highly encourage you to reconnect with nature at some point. And forest bathing is always good to optimize the heart rate variability. Post-op, I call it week one after passing my boards. So getting back into the swing of things at the office, as well as doing some things I wanted to be doing. So saw some good questions popping in tonight, so we're going to answer those. And if you have any questions while we're going, pop them in the comments and happy to answer them. So the first question up tonight is, what is the best way to remove plaque from the carotid arteries? Chelation. Answer probably is not chelation unless you're diabetic and you fit the criteria of the TACT trial, T-A-C-T trial. I was at the recent April 2024 event in Atlanta with American College of Cardiology, where they presented the data on the TACT-2 trial and basically showed that chelation was not useful at regressing plaque in patients. So first, always get the root cause analysis, what is driving the plaque. So look at things that affect the endothelium and the endothelial glycocalyx, support those if needed. Look at how much oxidative stress and inflammation is present and lower those if they're elevated. And then use whatever tool you need to optimize the lipoproteins. So if you stop doing the damage, the body is pretty good at getting back to homeostasis and trying to regress the plaque. So this just tags along with the previous question. Can mild atherosclerosis be reversed? Absolutely. I've seen it in my own carotid intimal thickness scans where I've had some intimal thickening improve when partly I got out of the cath lab and stopped getting radiation to the left side of my body. And I've seen my clearly results improve greater than 6% in approximately 2 years. So the plaque shrank by optimizing the endothelium and the glycocalyx. And I've never had issues with inflammation or oxidative stress, but had some mild dyslipidemia. I mostly focused on optimizing the endothelium and the glycocalyx. I wasn't doing a lot for the dyslipidemia, and the atherosclerosis improved. So think of your lining of your arteries as like Teflon or a protective shield. If that coating is healthy, you stop doing damage to the arteries. And then the body can get to work at repairing what's in the walls of the arteries. Next question up. Do I favor CT scans over echo stress test and I assume echocardiogram? CT was bad and echo were normal. All right, so it's going to depend a little bit on what the use case is for each test, so I'll walk you through it. So the CT scans often are going to be either a CT coronary calcium scan or a CT coronary angiogram. So both of those are looking at plaque in the arteries. The CT angiogram looks for the degree of stenosis or blockage in the arteries. Often used if you're having symptoms, chest pain, shortness of breath, exercise intolerance. Same thing with the stress test. Stress tests are really good if you're having symptoms and you're trying to recreate that under stress. Stress tests are very poor at telling you who's at risk of a heart attack, because the stress test will often be normal unless you have a severe blockage in one of your arteries. And a severe blockage is generally 70% or greater in one of your arteries. So you can have a elevated CT coronary calcium scan or abnormal CT angiogram, mindful that you probably don't have a 70% blockage on the CT angiogram, and then your stress echo can be completely normal. So often you will use both tests, but it's the plaque that's the problem, and that's what you're wanting to treat. This is a question I don't know the answer to, so you're going to have to provide some more comments on this one. But somebody says that they're a 65-year-old man with a blood pressure of 110/60 and has one kidney, takes 350 magnesium and is tired. So you did not mention how well your other kidney is working. Do you have chronic kidney disease and have high uremia? Are you anemic because of the chronic kidney disease? There's a lot of things that cause people to be fatigued. Magnesium helps 3 to 4 different reactions of the body, but taking more magnesium isn't likely to improve the symptoms. So we need more background on that. Probably need more testing. And then a question, is salt bad for you if you have hypertension? It's a qualified maybe. The glycocalyx, the protective gel coat in the arteries, it buffers sodium. So if you have a healthy glycocalyx, you can tolerate more sodium. If you have an unhealthy glycocalyx, you can't tolerate as much sodium without causing increases aldosterone, which then holds onto water, which then raises blood pressure. So it's not bad for everybody who has hypertension. Some people are more sensitive than others. And so most people ultimately understand if they're sensitive to sodium raising their blood pressure. That's why it's best to always monitor your blood pressure at home if you have a history of hypertension. And if your blood pressure is increasing, look at your lifestyle. What has changed? Are you changing your sodium intake, your caffeine intake, your alcohol intake? Is your sleep off? There's something that's driving it. But one of it is, you're probably not getting appropriate sun exposure all the time. You need a lot of UVA light to liberate nitric oxide from your surfaces to keep normal blood pressure. All right. How does DHA relate to cardiovascular disease? You need DHA to basically capture sunlight energy and transform it as a DC electric current to all your mitochondria and the rest of your cells, including your heart. DHA is important to stabilize plaques that are in the walls of the artery. So high omega-3s can take plaques that are more prone to rupturing and potentially stabilize them. Not by itself, but it's one of the tools that can be utilized. So DHA may have an effect as well at reducing cardiovascular arrhythmias. So it's very important for cardiovascular disease to check your omega check levels and your EPA and DHA levels. Question, daily aspirin to help with elevated LPA? Often the answer is yes. It may reduce the risk of stroke and heart attack. There are certain LPA SNPs or genes that can be assessed that tells you who's more likely to benefit from aspirin than not. But most people, unless they have an aspirin allergy, or they have unknown anemia, generally benefit from being on aspirin therapy if they have a high LPA. Can anything other than lowering ApoB mitigate the effects of elevated LPA? So lots of LPA questions tonight. And this is not a beer, this is Topo Chico. All right, so typically I look at LPA as something as, is it actually likely to be damaging arteries at this point? Today I spent time talking to some of my patients all around the country, and many of the patients had high LPA, so this was the topic of discussion today. So LPA, very much like LDL, it carries different cargo. It carries oxidized phospholipids. So it's basically like a garbage truck, and if it's full of oxidized products and then LPA gets stuck in your arteries, it's going to drop that off and you're going to have a more aggressive inflammatory response inside the arteries. So there's a couple tests you can look at on typically the Boston Heart Lab panel, but Cleveland Heart Lab does some as well, is you can look at Lp(PLA2) activity. That enzyme, if it's elevated, indicates that the arteries are inflamed and that LPA is carrying around a lot of oxidized phospholipids. You can look at directly the oxidized phospholipids. The more sensitive one is oxidized phospholipid ApoB, available with Boston Heart Lab. The other lab you can look at is interleukin 6. If interleukin 6 is high, the liver is going to keep pumping out more and more copies of LPLA. So green is good on a lot of these tests. If you have normal Lp(PLA2) activity, oxidized phospholipid ApoB, and interleukin 6, less likely LPA is actually injuring your arteries. But the only way to know for sure is to do some type of test that looks at the arteries, like a carotid intimal medial thickness scan, or a calcium score, or a CT angiogram. So it's a way to look at the arteries, determines how aggressive to be with the rest of the treatments. Lowering ApoB on your LDL particles is one part of the equation. Somebody says that their husband has kidney disease and blood pressure is high on medication. Any suggestions? Obviously I can't give individual medical advice, but it depends on what stage of chronic kidney disease, how much microalbuminuria is present, how well is the blood pressure controlled. Blood pressure when you have chronic kidney disease generally should always consistently be less than 130/80 in the office or at home. Often, patients should be on an ACE inhibitor or angiotensin receptor blocker if they have kidney disease. And if you have chronic kidney disease, you may have vascular disease in your heart. So if you've not had a CT coronary calcium scan, you may want to start with that to see what is your risk. Because people who have kidney disease, the number one thing they die from is vascular disease. not necessarily the kidney disease directly. Somebody says, did I hear you say once you have a PCP approach to cardiovascular workup outlined in a video? I don't know exactly what that means. I don't have a video directly for primary docs, but a lot of my videos in the archives of Instagram or on my YouTube channel, which is, I have the website, Dr. Twyman, spelled up like this, .tv. That'll forward to my YouTube channel. There are some videos there where I talk about the different tests that I offer in my office to work people up to assess the risk of vascular disease or to see the degree of vascular disease they have. But typically, it's looking at vascular disease as a systemic process. It's in 60,000 miles of your system. You can look at the carotid artery on the side of your neck. You can look at the heart arteries. You can look at your abdominal aorta. You can look at the blood vessels in your legs to see if you have peripheral arterial disease. There's testing that looks at arterial stiffness called the max pulse. There's tests that look at endothelial function called the endopat. Then a whole host of biomarkers with either Boston Heart Lab or Cleveland Heart Lab. And then when needed, genetic markers, generally with either Vibra America or cardiacs to figure out, okay, what did you inherit from mom and dad that put you at a higher risk? What do I know about calcium supplements and heart valve stenosis? A lot. I'm board certified, but not to be smug about it, is that it depends on what else is in the supplements that you're taking. If you have osteoporosis and you're on calcium, roger that, but you need to have optimal vitamin D levels, ideally from the sun, not from supplementation. For vascular reasons, I generally want to see people's vitamin D levels 60. And then for calcium to go where you need it to be, your bones and not your arteries or on the outside of your valves, you need vitamin K2 to be present. Vitamin K2, in addition to vitamin D, will shuttle the calcium into your bones and teeth and prevent it from building up in your arteries and on your valves. You also need to kind of look at oxidative stress and inflammation, because as often if you have high inflammation and the glycocalyx, the lining of the valves is damaged, you're more likely to calcify the valves. So roundabout answer, there are patients that will benefit from calcium supplements, but not as many as you would think, and you must have optimal vitamin D levels and K2 levels to keep calcium where it needs to go. All right, question up. What causes lead to high heart rate over time, consistently over 110? How to solve naturally? So it would depend a little bit on how old you are to begin with. Where did the heart rate start? And are there any other associated symptoms is what I would look at. The quote average heart rate is going to be between 60 and 100. But there is, 2.5% of the population, a heart rate over 100 is normal for them. Is 110, are you having shortness of breath, palpitations, chest pain, exercise intolerance? If you're having symptoms, definitely more concerning. Blood work that I would look at is, are you anemic? Do you have low red blood cell counts? Are you hypothyroid, or I should say hyperthyroid, if your thyroid's overactive? And then potentially would wear a Holter monitor to see, does your heart rate change throughout the day? Is it going down while you sleep? And then may or may not recommend, a just plain treadmill stress test. Not necessarily looking for, quote, blockages in your arteries, but to seeing how well does your heart rate recover with exercise. Typically your heart rate should drop at least 12 beats in the first minute after exercise is complete. If not, then there may be some other issue where your body's being, quote, stressed and your body's not able to recover. So maybe it's a norepinephrine problem. So there's multiple reasons that the heart rate can be high, but it really depends on if you have symptoms, and then you go from there. And then the question, are the heart pumping capacity and heart rate connected somehow? And if so, how? So heart rate is just the number of beats per minute. And then the heart pumping capacity, most people would probably equate that as your ejection fraction, how much blood is pumped out of your heart at each time. If you're being very scientific, you'd be more your stroke volume, the actual milliliters of blood being pumped at each time. But your stroke volume times your heart rate is your cardiac output, so that's how they're connected. All right, so those were the pre-submitted questions. I see a few familiar faces in here tonight, and I saw a couple questions pop up while I was answering the pre-submitted ones. So we'll get to those. Would chelation help lower a high calcium score? For the most part, the answer is no. And if it did, you don't honestly know, is that a good thing? Because calcium is often a stabilizing factor. If you pull the calcium out of a plaque, did you leave it more unstable? That is an unknown. The best way to think about chelation is that it removes heavy metals from the body so that it calms down oxidative stress and inflammation. And then the body gets to work at repairing any damage that's still present. It says, I think it's a calcium scan, but it says CC scan 80% plaque in the circumflex, no symptoms. Is plaque definitely inside the vessel? So hard to tell for sure without seeing the actual reported images, but often tell patients think of plaque as like an iceberg. It's growing in the walls of the arteries for many years before the tip of the iceberg gets above the ocean surface and starts occluding the blood flow in the lumen where the blood flows. But if you already have an 80% stenosis that's occluding the lumen, then definitely you have plaque in the vessel as well. But if you're asymptomatic, then you don't necessarily need a stent or surgery, but should do a deep dive analysis while you're developing the plaque and then come up with a plan on how to stabilize that plaque and prevent further plaques from building up. Somebody's asking, how did I reverse my plaque without prescription medication? Great question. Yeah, now that I'm done studying for boards, I'll eventually be able to sit down and put together a longer form video on my most recent Clearly scan. That's in the short list. I don't have an exact time frame, but if you held me to it, it'll be done within the month. I have a new space at Apollo Cardiology where I'm setting up as kind of a mini podcast studio. So once I got my lights, camera set up, I'll sit down and record that video for you guys. And when I record it, yeah, I'll put it on my YouTube channel. But I basically did a comprehensive blood work panel. I was doing Cleveland Heart Labs on myself at that time. Other than my ApoB, I really have no abnormalities in my labs, and I'm checking 300 different factors. I have no oxidative stress or inflammation. My hormones are optimal. I don't have LPLA. I just have a 50th percentile ApoB. So was doing things that supported nitric oxide in the glycocalyx. So was taking Vascinox arteriosol for those. So help build up basically what I call a force field. So high nitric oxide levels, less likely any lipoproteins stick to the arteries. Was taking Kyloic garlic. Kyloic garlic has been shown to stabilize plaques. They've looked at calcium scores, where calcium scores actually will get better for that. So if people are wanting their calcium scores to get better, Kyloic garlic is a better option than chelation. And then I do the things that I do. So, I optimize my sleep. My circadian rhythms have been dialed in since, for the most part, 2017. I meditate every single day. I was looking at my app recently, and it said I had, I believe, 71,000 minutes of meditation in the past 5 years. So, got my autonomic nervous system as balanced as I can. My nutrition's generally, pretty paleo-based. Slightly Mediterranean as well. Not super strict on it. And then exercise is probably my weakest point. I don't get as much zone 2 as I particularly would like, but doing some decent amount of strength training with either X3, and then in the past 10 months been doing some ARX at BioFit here in St. Louis. So doing things I teach you guys here and teach patients at Apollo Cardiology is make an intervention and then retest. And so when I retested my Clearly 2 years after doing the initial one, the salt plaque shrank 6%, which is actually a very good number. Statins, if you're on them, best case, 1 to 2% plaque regression. Statins are good tools, but I got to do better than statins alone. And partly, I wanted to prove to myself that the glycocalyx was that important. So I can biohack myself because I'm the one who's at risk. But when I proved it to myself, then it was more of a kind of thing that I could talk to patients like, this is something to really focus on. Keep a healthy endothelium and glycocalyx, and you're much less likely to continue to add plaque. We're still going to discuss your lipoproteins, but it's not so simplistic. High ApoB means has to be 0. You have to fix the oxidative stress inflammation and support the glycocalyx if it's not optimal. But that's a very good question, and I'll go in much more depth of that when I put together that YouTube video. All right. Well, the sun is rapidly setting here. I'm becoming more red light. There's no filter on this tonight. So I always appreciate your guys' time and attention. You're asking some great questions. These are the things I get asked a lot in my office. And so this always helps me kind of prep for them as well. If you're potentially interested in working with us, if you go to my website, drtwyman.com, there's an application. My team, Cassidy or Dow, will speak to you about how to potentially work with us if you're interested. We, yes, are still open to patients. I can't say yet that that's going to be forever. I don't know exactly when I'll hit capacity, but it's just myself, Dow, and Cassidy seeing people all over the country, and we're doing a pretty good job keeping up with demand so far. But if you're interested potentially to work with us, you can click on the application on my website. All right. And then you're saying, oh yeah, so you're very welcome for the explanation. That's what I like to do, is try to give very clear, concise things that help people understand how their bodies actually work. I understand sometimes medicine is very complicated. It's sometimes a foreign language. I think one of my skill sets is being able to decipher it and explain it in a language where people understand how things actually work. And then let's see, one last question here. I'll answer this one for you guys, and I'll let you go. And I'm gonna go read up on some gear that I want to get for my podcast studio. So I'll let you know what I've researched on that next week. But the question is, how can high cholesterol affect the heart? It's, how does it affect it? Well, cholesterol by itself is not the problem. Cholesterol is needed by your body. You make hormones with it. Your cell membranes are using it. You use it to make your vitamin D and your other sex hormones. So cholesterol is not the boogeyman. It's not put into you to give you a heart attack or stroke or block up your arteries. But if cholesterol, which is being transported in a lipoprotein, a lipid protein carrier, gets stuck in your arteries, it would cause inflammation in the arteries. So think of a lipoprotein as a cargo ship. Or in my office, I often use a tennis ball to show people kind of visually what it looks like. The cholesterol goes inside that tennis ball. If that tennis ball gets stuck in your arteries, it's like getting a splinter in your arteries. That then causes inflammation. The arteries start to swell, and as more and more cholesterol particles get retained, more and more cholesterol gets deposited. The cholesterol crystallizes. More and more plaque starts to form. And think of plaque as almost like a pimple on the wall of the artery. And then that plaque continues to build, and your body keeps trying to form a scar. It'll put smooth muscle over that scar. It eventually may calcify the scar. But if the calcifications don't hold, or the plaque continues to build aggressively, the plaque ruptures. And then when the plaque ruptures, the cholesterol spills out back into the bloodstream, the blood clots, and the person has a heart attack or stroke, depending where the plaque ruptures. So cholesterol can affect the heart. It is not the only thing that affects the heart. That's why I put so much interest and attention to teaching people about nitric oxide, the endothelium, and the glycocalyx. That stuff has to be bulletproof. That is how you become heart attack proof. If you have a healthy endothelium and glycocalyx, the cholesterol never really gets a chance to get stuck in the arteries and cause the plaques. All right. So everybody's very welcome. And so he says they missed it. Yes, this will be on replay every time. I leave it in the archives. And then I think if you just go to my storyboard, you can look years and years worth of my previous Ask Me Anythings. But I'm going to get back in the habit of taking these also and putting them back on my YouTube channel. I got a little bit more free time since I got done with the boards. So have a great rest of the week, guys. And we'll see you next Monday, 6 p.m. Central Time.